Welcome, ladies and gentlemen. I'm Dr. Silva, and today I'm going to talk to you about Schizotypal Personality Disorder. And I just did the video on Schizoid Personality Disorder, and maybe I might recommend that you guys watch that one first if you're interested in this group, this cluster of personality disorders, cluster A, because they really are on a spectrum. And the DSM, the way the current nosology characterizes these conditions, they use a categorical perspective. The idea that personality disorders are qualitatively distinct clinical syndromes that are grouped into clusters where they have similar symptoms, but not necessarily the same root causes or the same disease processes. So they don't necessarily share etiologies or pathophysiologies, respectively. But you've got this cluster here full of anxiety, this cluster here full of drama and impulsivity, and the cluster that I'm talking about here that contains schizoid and schizotypal personality disorders. I really see these conditions on a spectrum. Cluster A, which contains the schizoid and schizotypal personality disorders, as well as paranoid personality disorders. And so those are the bizarre, eccentric cluster, the weird cluster, quote unquote, weird cluster. And that's the current nosology. That's how they are choosing to classify these conditions. But there's another way that's actually mentioned in the DSM. It is an alternate perspective, a dimensional perspective, which states that personality disorders represent maladaptive variants of personality traits that merge imperceptibly into normality and into one another, as well as other psychiatric conditions. So what we're talking about is a spectrum of severity. That's a very common phrase nowadays, being on the spectrum. People say, I think I'm on the spectrum, or I think he's on the spectrum. They're alluding to autism because all of the autistic disorders from Asperger's on up, they were all renamed, reclassified under one umbrella called autism spectrum disorder. And so people say on the spectrum. There are spectra that could encompass any of the diagnostic categories. So there can be a psychotic spectrum, there can be a major mood spectrum, a bipolar spectrum. That's a parlance that's actually in use, bipolar spectrum, from bipolar type 2 to full-blown manic depression. So I like this secondary classification better because it doesn't pretend that these conditions are all different illnesses. Now, across the board, because they're syndromes, across the board, if you say you've got two individuals that have schizotypal personality disorder, they don't necessarily have the same illness. They have the same syndrome, but they may have disparate etiologies and disparate pathophysiologies. So the root causes and the actual disease processes may be different in both of these individuals who meet diagnostic criteria for schizotypal personality disorder. That's true of all psychiatric conditions. They're all syndromes. Unless you're talking about very specific, like hypothyroid-induced depression, well, then that has a very specific pathophysiology. But most of the conditions are syndromal. But in any given individual, if you have an individual who is diagnosed with schizoid personality disorder, say for example, and then goes on to quote unquote develop schizotypal personality disorder or schizophrenia, well, that was the same condition in that one individual. They didn't develop these other conditions. The condition that they had in childhood or late adolescence evolved into this more serious condition. Whatever was wrong with the brain genetically, in the vast majority of cases, then developed into, evolved. The condition developed, but the individual didn't develop a new condition. So semantics, it's important. Language is important. But the point I'm trying to make here, and that I made in my previous video, is that these conditions overlap. That's why they're clustered together. But specifically schizoid and schizotypal, there's a lot of overlap. They bleed into one another, and both can go on to become schizophrenia. So I think the idea that these aren't necessarily discrete conditions, but that they're on a spectrum of severity is probably closer to the truth. And the DSM even goes on to state that when an individual has a persistent psychotic disorder, such as schizophrenia, that was preceded by either schizoid or schizotypal personality disorder, and for that matter, paranoid personality disorder as well, all of the cluster A personality disorders, then we're supposed to record that the schizotypal personality disorder diagnosis, for example, was quote-unquote pre-morbid. And we're to put that in parentheses, following the diagnosis of schizotypal personality disorder. So they still instruct clinicians to diagnose both things and document both things. So they had schizotypal personality disorder when they were 17 and 18, but by the time they reached the age of 20, they had developed schizophrenia. And so now we're going to say that schizotypal personality disorder was pre-morbid. I personally don't like that method of classifying disease because they're two different conditions. You're stating explicitly that you had this pre-morbid condition and then you had this other condition. And it implies that they're different illnesses. They may be different conditions, syndromally, if you look at it that way. But if you look at it in terms of what is the etiology, what is the cause, where did this illness come from? These illnesses, they're not two illnesses. It's one illness. It's obviously one illness, and it just got worse. And so, inasmuch as schizotypal personality disorder can sometimes be part of the prodrome of schizophrenia, I don't think it's right to call it a personality disorder. There's something wrong with their brain. Even patients who don't go on to develop schizophrenia, it's clearly endogenous. It's clearly something wrong with the brain. And I think retroactively, instead of putting pre-morbid in parentheses, retroactively we should say, well, it wasn't schizotypal personality disorder after all. It was really early schizophrenia. So those cases that don't go on to develop schizophrenia, we need this diagnosis. We need this diagnostic category because some don't, most don't. But when it does, I think it's the same illness. You have to presume that's just elegance. That's Occam's razor. Why would you presume that they have two different illnesses, both of which lead to the same types of symptoms? So the differential diagnosis includes other psychotic disorders as well as autism and persistent substance abuse that might cause psychosis and other personality disorders. So the criterion A for schizotypal personality disorder states that the core dysfunction, what every patient that is diagnosed with this condition must meet, a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, like schizoid personality disorder, as well as cognitive or perceptual distortions and eccentricities of behavior. So that's the piece that we don't have with schizoid personality. Also, there's a lot of anxiety with schizotypal personality disorder as opposed to schizoid. In schizoid personality disorder, those individuals seem indifferent to their social ineptitude, whereas here you have social anxiety. In fact, we have a whole criterion. Of the 9 criteria, 1 is devoted to social anxiety. So that's very different. And these individuals tend to complain of this as opposed to the schizoid individual. The schizoid individual appears to be more clueless about the social impairment. But like all personality disorders, these symptoms must appear by early adulthood and they must be present across the board in a variety of contexts. So personality disorders don't develop in middle age or in a person's 60s or 70s, and they don't just occur at work or just at home or in the context of this or that relationship. As far as the researchers are concerned, you have to meet 5 out of these 9 diagnostic criteria in order to qualify for a diagnosis of schizotypal personality disorder when they're researching and when they're studying it. But in the real world, in the clinical world, a clinician is going to make the diagnosis if there are enough of these criteria and they're severe enough. Here are the 9 symptom categories. Number 1, ideas of reference. Ideas of reference are when an individual believes that things that are going on in the environment, events and statements, if they overhear people, that they believe that that phenomena refers to them. They have an idea that those external things are referring to them, ideas of reference. And This, though, excludes delusions of reference. So there's a difference between believing that, hey, they're talking about me, and no, the newscaster on TV, the CNN newscaster, they're talking about me. It's not always negative. It can also be grandiose, because a person could believe that they're so famous and their deeds are so renowned that, hey, they're talking about me on the news. They heard about the wonderful thing that I did. So what we're talking about is paranoia. Ideas of reference equals paranoia. And you can be a little paranoid and be able to be talked out of it. So you're not necessarily delusional if you're paranoid, but hardcore paranoia that cannot be dissuaded is delusional. And so these ideas of reference could rise to the level of delusional intensity, but that's not what they're talking about here. This criterion is the softer ideas of reference. But in schizophrenia, an extreme example of this is you can see that a person believes that the people on TV are talking about them and their deeds, ill or good. And when they're really psychotic, it could be the characters on a sitcom, right? Not even the news. These characters on a sitcom that maybe aired in the 1970s, they're talking about what I did yesterday. That's possible that a person could be that delusional, and you can't talk them out of it. Logic doesn't work. But again, here we're not talking about that intensity. We're talking about non-delusional paranoia. And the paranoia, however, is made more explicit in criterion 5. I'll get to that in just a minute. But the beliefs are not held with delusional conviction. The DSM defines ideas of reference as incorrect interpretations of casual incidents and external events as having a particular or unusual meaning specific for the person. So it's not always they're talking about me, but somehow that thing that is happening that's just completely coincidental, somehow it's about me, or its meaning, its significance pertains to me, because they are a little paranoid. Number 2, odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. So these individuals might be superstitious or preoccupied with paranormal phenomena, again, that are outside the norms of their subculture. So there are culturally sanctioned exceptions to this, but if their subculture doesn't support these beliefs, believing in telepathy or clairvoyance, believing that if your husband walked the dog because you were just thinking that he needs to walk the dog, that is magical thinking. That your thoughts influence reality, or that you can control others. All of that is included in this criterion. And so these patients are out of touch with reality. And whether you call it delusional or not depends on how convinced they are. And so if they just have a tendency to believe these things, but you can sit them down and with logic kind of get them to say, all right, well, maybe it's not true, but that sure did seem like it, then they're not delusional. However, they could very well be delusional. They could very well say, no, it happens all the time. I can read your mind. Now, there are exceptions to this. They're called culturally sanctioned delusions. And that's where you have these bizarre ideas, bizarre meaning that it's not plausible. It couldn't happen. So you could have a delusion that is plausible, that it might happen. People might be plotting against you. They might be talking about you. But if you believe that aliens came down and did these things, there are probably aliens, but they're so far away from us that the idea of aliens abducting you and running experiments on you and then returning you, that's a bizarre delusion. Or the idea that if you don't circle a light post 3 times, then your loved ones are all going to die of COVID. That almost has some obsessive compulsive flavor. But that's a bizarre delusion because it's not part of reality. It's not possible. But culturally sanctioned delusions can include the bizarre. And so it would be, for example, like believing in voodoo. And there is a subculture. There's a region of the United States and a subculture that believes that you can cast spells on people, curses, and that you can take dolls and you can put pins in them and that will make that person sick. And there are people that really believe that. But what's the point of saying, well, it's culturally sanctioned? Well, the point is that you don't give those patients, those individuals, let me say, they're not even patients, right? People that believe in voodoo, they're not going to present for treatment. I hope this is not offending anybody out there who may be watching this who was raised in a culture that believed in voodoo. But the point is that they don't present for treatment, and you don't treat them, you don't give them D2 blockers, dopamine antagonists, because that's not going to help. There's nothing wrong with their brain. They were raised into that belief. So other examples that are given in the DSM are belief in life beyond death. That's most religions. Speaking in tongues, shamanism, mind reading, sixth sense, having a sixth sense, the evil eye, magical beliefs related to health and illness. That's the evil eye. So there are a lot of examples. If somebody believed in the tooth fairy and you really couldn't convince them, now children, it's an exemption. So it's culturally appropriate, it's developmentally and age appropriate if you're very little to believe in the tooth fairy and Santa Claus and the Easter Bunny. But then as you get older, the culture no longer sanctions it. It will sanction it until you're a certain age. Then it becomes a symptom, it becomes problematic. And truthfully, if a child continued to believe in Santa Claus well into adulthood, well, that would be a delusion, and there is something wrong with their brain because they're not accepting what society is now telling them, which is, sorry to break it to you, kid, but we all lied to you when you were little. And if the child won't accept that, then there are going to be other symptoms of psychosis. There is something wrong. Number 3, unusual perceptual experiences, including bodily illusions. Perceptual alterations may be present in these individuals. For example, sensing that there's somebody in the room, or maybe hearing a voice murmuring their name, just very softly whispering. The criteria, the DSM doesn't call it hallucinations, it calls it an illusion. The difference between an illusion and a hallucination is that there's no stimulus for a hallucination. You're hearing or seeing or smelling or feeling. There are all kinds of auditory, visual, tactile, olfactory, all different kinds of hallucinations. But the brain is registering sensory input where there is no sensory input. It just bypasses that step. Illusions, in contrast, there is a stimulus, but maybe because the room is dark, or the person's half asleep, or they've taken a drug, they are misperceiving that stimulus. And so the air conditioner might be on, there might be some white noise in the background, but they hear softly their name being murmured. That's the interpretation that the brain makes. They're not hallucinating. It's not outright voices when the room is quiet. Still, this is a psychotic symptom. These are the seeds of psychosis, the seeds of hallucinations. Number 4, odd thinking and speech. Examples: vague, circumstantial, metaphorical, over-elaborate, or stereotyped speech. And this is evidence of a formal thought disorder. So in psychiatry, there's 2 kinds of thought disorders, problems with thought: form and content. So when we say it's a formal thought disorder, we're saying we're not talking about the content. I just talked about the content. We're talking about the form of the thought is disordered. There's something wrong with the associations between thoughts. So it's zigzagging. And this is also a spectrum. It's also, like everything else I'm talking about, it can be mild, in which case a person is what we call circumstantial or over-inclusive in their speech. They're giving too many examples, or they are going off on a little tangent, but then they come back. So they eventually get back to what they're talking about, but it's too many details and they're irrelevant. And it's a sign that sometimes people do that when they're nervous, and they do it. There's lots of reasons why a person might do it, but it is a problem with brain chemistry that is leading to thought and speech, because that's how you detect it in speech, that is not concise and it's not goal-oriented. There's something wrong with how they're thinking because they're giving you this. And there are individuals who do this chronically. There are individuals who have a characteristic of doing it. I think obsessive compulsive disorder can lead to it. When you don't get back to the point and you go off on tangents and you never finish what you were saying, that's tangentiality. That's the same formal thought disorder, but it's to a more severe degree. And when it's really bad, not only do you go off on a tangent, but you never finish any of your tangents, and you have what's called a flight of ideas. And that's often accompanied by psychomotor agitation. So you also see a pressure of speech. Not only are they having all these ideas, but the ideas are in flight. It's kind of fast. They may be talking fast. It's usually a sign of mania. And at the most extreme, what we used to call Schizophrenia is something called word salad, where it's just a bunch of words and phrases and it's not even sentences. It's not making any sense at all. And I've probably seen that one time. I saw it one time, but this woman was on drugs and she was very, very agitated. Now, I've just given you this spectrum, but the discussion in the DSM rules out the more severe form. So they may be loose, digressive, and vague, but you don't see the actual derailment or incoherence that you see in an individual whose associations are even looser. So you don't really see tangentiality. Or if you do, it's very mild. As with criterion 1, which indicates paranoia but stops short of frank psychosis by excluding ideas of delusional intensity, criterion 4 indicates disorganized speech, another symptom on the psychotic spectrum, but excludes derailment/incoherence, thereby once again limiting what is otherwise a clear indication of psychosis. The diagnostic criteria do this to differentiate schizotypal personality disorder from acute psychotic illnesses such as schizophrenia and delusional disorder. In addition to speech that's not goal-oriented, speech can include unusual or idiosyncratic phrases and construction. In other words, speech can be stilted. Their speech can also be affected by overly concrete or overly abstract words or concepts. Words that are sometimes applied in unusual ways. For example, instead of saying that they weren't very talkative at work, they might say, I wasn't very talkable at work. Talkable, a neologism. That's the example that's given in the DSM. You might see speech that's just, it's odd. People don't really talk that way. They're using speech and language in odd ways, and it's because of a formal thought disorder. There's something wrong with the form of their thought, the words that they're choosing, and it's because their associations are loose. Number 5, suspiciousness or paranoid ideation. So here you're seeing what criterion number 1 was hinting at, that the individual is actually paranoid. They do believe that they're the center of the universe. We all kind of have that perception. That's part of our ego, but these people are suspicious. They don't trust other people, and they believe that other people are trying to harm them, that they have malevolent motives. Number 6, inappropriate or constricted affect. We saw this also with schizoid personality. Quote, they're usually not able to negotiate the full range of affects and interpersonal cueing required for successful relationships, and thus often appear to interact with others in an inappropriate, stiff, or constricted fashion. The affect is the emotional expressions. So it's your facial expressions, it's the tonality of your voice, inflection, the prosody of your speech, body language. It is how you get your point across. It's a non-verbal communication, and it's very important. And when individuals are on the psychotic spectrum, they begin to lose the ability, and their affect becomes more and more constricted. This is a spectrum as well. It starts out with a restricted or constricted affect, which then is blunted, and when it's completely flat, that is indicative of psychosis. And I do talk about this in my schizoid video as well in a little bit more detail, so I really encourage you to check that video out. This is really a 2-part video package. It's a bundle. They really go together because this is sort of a progression of schizoid personality. Not necessarily in any given individual or across the board, but conceptually in terms of the way that we classify disease. And so it overlaps with autism as well in the fact that you're not picking up on social clues. But there's also anxiety, and I'll get to that in a moment. Number 7, behavior or appearance that is odd, eccentric, or peculiar. We don't see this with the schizoid personality. Note, this also includes their appearance, not just their behavior. So in addition to unusual mannerisms and a weird way of talking and relating to other people and a constricted or blunted affect, these individuals are often unkempt in dress. So for example, wearing ill-fitting clothing, maybe the buttons are off and they don't really notice and they don't seem to be attentive to that. Or maybe they've got an ink stain or some other kind of stain. They put the clothes on, they were oblivious to it. This, coupled with being inattentive to social conventions like making eye contact or being able to engage in small talk or office banter with coworkers or appreciating a sense of humor. That's what this criterion is about. And this is why this individual, in both behavior and appearance, seems weird. The mnemonic for clustering these personality disorders, A, B, and C, is weird, wild, and worried. That's just the mnemonic. But officially, these individuals are bizarre and eccentric. Number 8, lack of close friends or confidants other than first-degree relatives, parents and siblings. This is also in the schizoid criteria, but these individuals are anxious about it. According to the DSM, they experience interpersonal relatedness as problematic, and they are consciously uncomfortable relating to other people. They also complain about it because this is something that is known. The DSM goes on to say that although they may express unhappiness about their lack of relationships, their behavior suggests a decreased desire for intimate contacts. As a result, they usually have no or few close friends or confidants other than a first-degree relative. I think it's interesting that the DSM is second-guessing individuals here. If they're complaining about it, unlike the schizoid personality, if they're complaining that they don't feel comfortable and they want to be close to people, they want a girlfriend, but they don't know what to say and they feel uncomfortable, for them then to behave in a way in which they don't ask anybody out, and you can't take that behavior and then say, you know what, they probably have a decreased desire for it. They're complaining to you about it. So how could you possibly second guess them and say, but based on their behavior, I don't think they want it. I object to that statement in the DSM. I think, how on earth could you justify that speculation? That's second guessing the patient. If they're complaining about it, they obviously have a desire for it. Now, maybe some individuals don't, and the schizoid personality, they are characterized by that. They appear to not. That's one thing, because they're not complaining about it, the schizoid personality. And they don't have any anxiety about how others will perceive them. But these people have anxiety. In fact, criterion number 9 explicitly states excessive social anxiety that does not diminish with familiarity and tends to be associated with paranoid fears rather than negative judgments about self. So we don't see this at all in the schizoid personality. They do not have social anxiety. These individuals do, but unlike persons with social anxiety disorder, or for that matter, avoidant personality disorder, they don't relax as they get to know people. Instead, they become, quote unquote, increasingly tense and suspicious because they're paranoid. And so they're not worried that other people are judging them and that they're not coming across well. They don't really have that concern. What they're worried about is, what are these people going to do and say to harm me or to exploit me, to take advantage of me as they get to know me? They're anxious in social situations, particularly involving unfamiliar people. And they prefer to keep to themselves because they feel that they're different and just do not fit in. They seem to have more insight than schizoid personality, even though they also seem to be on a more severe course in terms of the psychotic spectrum. Their social anxiety does not easily abate even when they spend more time in the setting or become more familiar with the other people, because the anxiety is associated with suspiciousness regarding others' motivations. Exclusion criterion B states that these symptoms do not occur exclusively during the course of schizophrenia, bipolar or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder. Unlike individuals with schizoid personality, they often seek treatment, but they seek treatment for the associated symptoms of depression or anxiety, not for their paranoia, and not for other symptoms that they may have a lot less insight into. This is an uncommon condition. The prevalence is perhaps less than 1%. It does have a relatively stable course, with only a small proportion of individuals going on to develop schizophrenia or another psychotic disorder. My view, again, is that individuals don't, quote unquote, develop schizophrenia as though they're developing another condition. This condition, the schizotypal personality disorder, evolves into schizophrenia. It's part of the prodrome. Schizotypal personality disorder may be first apparent in childhood and adolescence in the form of solitariness, poor peer relationships, social anxiety, underachievement in school, hypersensitivity, peculiar thoughts and language, and bizarre fantasies. So even though children can believe in the tooth fairy and Santa Claus for a long time, I think what the DSM means is just really bizarre stuff coming from the child that is not typical for children of that age in that culture. But these kids can look very odd. It is something that starts young. The endogenous illnesses, the ones that are chemically mediated, that there's something wrong with the brain, and especially the ones that are degenerative, where they get worse over the lifespan, that are neurodegenerative, they start very, very early. And the seeds are there from infancy, really, but they don't manifest until usually adolescence. But a lot of times in childhood, the ones that are really bad, especially the ones that have social anxiety, they start very, very early. And you see that these kids are often teased and bullied because they're different. Schizotypal personality disorder appears to aggregate familially, and no surprise, it's more prevalent among first-degree biological relatives of individuals with schizophrenia compared to the general population. And it goes the other way as well. There may be a modest increase in schizophrenia and other psychotic disorders in relatives of probans with schizotypal personality disorder. Twin studies show highly stable genetic factors and rather transient environmental factors that give an increased risk for the schizotypal syndrome, i.e. nature beats out nurture by a long shot in these individuals. This is genetic. Or if it's not in the genes, it's probably in the genes, but it's a syndrome, so it's not necessarily one genetic disorder. But it could also have been due to in utero insults, and maybe a combination of that. Plus, there's always epigenetics. There's always, you have this vulnerability, this genetic vulnerability, but then the environment, nurture, not just the way you were treated and raised, but how the environment impinges upon you and how you develop and how much food is available and are you malnourished when you were a child. All these things can impinge upon the genome. It's called epigenetics, and that can determine how a particular propensity, predisposition is expressed. And now the more severe the disorder, the earlier it starts, and the more inexorable it is, and the less it matters whether your mom took care of herself and had good prenatal care, and whether or not you had nutritious meals as a child. It just depends on the severity. But if it's something more mild, then whether or not you actually develop even a condition as serious as schizophrenia could very well be determined by factors that are outside of just how your DNA is translated into proteins. And so this condition may be slightly more common in men. And the DSM says that particularly in response to stress, individuals with this disorder may experience transient psychotic episodes lasting minutes to hours. This is a curious statement to me because looking at these criteria, these individuals are psychotic They are mildly psychotic. They're psychotic. And so I don't know what the DSM is getting to when they say that in some cases, clinically significant psychotic symptoms may develop, quote unquote, that meet criteria for brief psychotic disorder, schizophreniform disorder, delusional disorder, or schizophrenia itself. And so I guess what they're saying is they may develop persistent psychotic symptoms that actually meet criteria for one of these disorders, schizophreniform, schizophrenia, brief psychotic disorder, because they are psychotic. It almost implies that they're not psychotic all the time, that they're only transiently psychotic. So I don't know how the DSM is defining psychosis, but when you're paranoid and your affect isn't right and you have magical thinking and you sometimes have illusions, I'm sorry, that's psychosis. So, but how do you treat this condition? With medicine. Medicine, and more medicine, and the earlier the better. Dopamine blockers, specifically the D2 dopamine receptor subtype. Thanks for watching.